I'm going to talk to you a little bit about cardiac conductivity and basics for interpreting EKGs. Here are your objectives. In the heart, you have two types of cells that allow for the heart to function as it does. You have the pacemaker or the electrical cells. And what these cells do are they conduct electrical impulses. And these electrical impulses that they elicit are going to allow for the heart to function as it does. It's going to allow for that muscle to contract. Your second type of cells are going to be your mechanical cells or your non pacemaker cells. And these are going to make up the bulk of the heart. And these are going to be the cells that actually contract in response to those pacemaker cells. The electrical system of the heart is actually pretty complex, but I'm going to do the best I can to break it down as simple as possible. So remember, we have pacemaker cells, which are going to be located throughout the heart, and they're going to work together to initiate that electrical impulse, which is going to excite those mechanical cells and allow them to contract. Well, we're going to have various groups of pacemaker sites in the heart. And our SA node is going to be our default or our inherent pacemaker site. So this is going to be where all of our electrical impulses begin under normal circumstances. And the SA node is located in the right atrium, and what it's going to do is elicit that response. It's going to travel down into the AV node, allowing for the atria to contract. It's going to continue that impulse down into the bundle of His and into the Purkinje fibers, which are located in the walls of the ventricles, allowing for the ventricles to contract as well. And I said this is our inherent or default pacemaker. And it's going to generally beat from 60 to 100 beats per minute. What's our normal heart rate? 60 to 100, right? But there are going to be situations, circumstances where the SA node can fire slower or faster, but that impulse is still coming from the SA node. For example, when we have sinus bradycardia, our impulse is coming from that SA node. It's just going a little slower than that inherent rate. Could it be from medications, certain well-trained athletes, hypothermia? Something is causing it to just beat slower, but it's still coming from that SA node. Now our AV node, just like with the SA node, it has an inherent rate of 40 to 60. And this is generally what it's going to beat, but there's going to be situations where it may beat slower or faster. And our last ditch pacemaker site is going to be our junction, and its inherent rate is going to be from 20 to 40 beats per minute. So if our SA node fails, our AV node picks up. Well, what if they both fail? Then our junction is going to try to take over. And again, there's going to be situations where it may beat slower than 20, and then there's going to be situations where it can beat faster than 40. And just remember, medicine is not black and white. So, although we learn this, know that there's going to be certain normal variations and there's going to be certain circumstances that can lead to variation. One cardiac cycle consists of three parts. You have your atrial systole, followed by your ventricle systole, and finally your ventricle diastole. And ultimately, your mechanical function should be negated by that electrical conduction, and it should mirror what's going on. For example, when your atria depolarize, that should lead to your atrial systole or contraction, which is going to occur very briefly before ventricular systole.
And that contraction of the atria is going to force more blood into the ventricles for when they contract, which is going to increase cardiac output. That atrial systole is called your atrial kick. Now, your ventricles are going to depolarize, and that should lead to your ventricular contraction. And when your ventricles relax, that is your ventricular diastole. That is when your ventricles are filling with blood, waiting for that next electrical signal, which will lead to a contraction so that blood can be pumped throughout the body.
Your EKG is going to measure the electrical activity of different parts of the heart. So it's going to show how impulses move through the atria and ventricles to produce that heartbeat. And with a 12 lead EKG, it is going to give us 12 different views of the heart, allowing for us to have a more comprehensive picture of where the problem is occurring and what exactly is occurring, allowing us to more pinpoint the specific areas and whether we have a problem with our atrial depolarization or if the problem is occurring within the ventricles. Now, although the 12 lead is pretty comprehensive, it doesn't always give us the greatest view of the right side of the heart. So sometimes you'll see if we suspect that there's issues occurring on the right side, you may see them use a 15 lead EKG and sometimes even an 18. EKGs and telemetry are very valuable tools in the clinical setting, but they do have their limitations. Remember, both your EKG and your telemetry are only measuring the electrical function of the heart, not the actual mechanical or pumping mechanism of the heart. But remember, the electrical conduction system is what is going to synchronize and initiate those impulses that lead to contraction. So ultimately, what we see occurring electrically should correspond to what the heart is doing mechanically. And an EKG, remember, is going to be very comprehensive. It's going to give us 12 different views of the heart, allowing us to see more areas of the heart and providing us with more detailed information. The downside of an EKG is it's only showing us what is occurring at that moment in time. A lot of times we're going to use telemetry, which is only going to allow us to view the heart from one lead at a time, generally lead two, but we can see what is occurring on an ongoing basis. So although it's not as specific, since we have continuous monitoring, we may be able to detect certain things faster. You will notice that EKGs are printed on grid paper, and this is because the grids are going to help us measure both time and voltage. A small square is going to represent 0.04 seconds, and a large square, which is made up of 5 small squares, is going to represent zero point 0.2 seconds. Now, I'm going to talk to you a little bit about what the different segments and waves represent in a cardiac cycle. Your P wave is going to represent atrial depolarization. So this is going to elicit the atria to contract and pump blood into the ventricles. Your QRS complex is going to be the ventricular depolarization. This is what elicits the ventricles to contract and push blood into your semilunar valves. Then you're going to have your T wave, and this represents when your ventricles repolarize or relax. Your atria also relax, but if you noticed, I didn't mention that there's a spot on the EKG that shows that. And that's because your PR segment, which is your atrial relaxation, is going to be hidden within your QRS complex. I want you to think about why. Your QRS complex represents ventricular depolarization. This is going to create a much larger waveform than when our atria relax or repolarize. And our normal measurement for our QRS should be less than 0.12 seconds. And for our PR interval, this is how long it takes for the signal to go from the atrium down into the ventricles. And this should be less than 0.20. If not, you have a heart block, a first degree heart block. Now, I'm going to talk to you a little bit about your QT interval, and this is going to represent the entire ventricular cardiac cycle, so the time it takes for the ventricles to contract and then to relax. I know you've probably heard of prolonged QT syndrome or medications that prolong QT intervals, and this can lead to life-threatening dysrhythmias. In women, our QT interval tends to be a little longer. It's going to be 0.46 seconds or less. And in men, it's going to be less than 0.44 seconds. And if it is greater than that, then that patient is known to have a prolonged QT interval. Interpreting EKGs can be overwhelming. And I think part of it is because we just want to be able to look at it and know what rhythm it is. And sometimes we can do that. However, interpreting EKGs is a systemic method that is going to involve 5 steps. And if you follow these 5 steps, you will be able to successfully interpret EKGs without feeling so overwhelmed. There are a few methods we can use to calculate the heart rate. One of them is the formula method, and you can do that when the rhythm is regular. And it's going to involve quite a few steps where you have to divide the number of large squares between the QRSs and blah-de-blah-de-blah-de. And me personally, I'm about as smart as a box of rocks. So I'm not going to do all that. I'm going to go with the easier method, and that is to count the number of R waves. Some people like to say, let me count the number of QRS complexes. And when we do this, we know that each EKG strip is going to be a 6-second view. So all we have to do to get the full minute is multiply that by 10. Let's practice here on option 1. 1, 2, 3, 4, 5, 6, 7, 8, 9. I have 9 full QRS complexes, or I see 9 full R waves. So I'm going to multiply that by the 10 seconds, and I know my heart rate is 90 beats per minute. The next step is going to be determine regularity. And how we do this is by looking at the distance between the R waves. Are they equal distances apart? What you're essentially doing is marching out each of these R waves to see if they are all the same distance apart. You can use calipers or markings on a pen and paper. And what you want to look for, is it regular? Such as this one. All of these are equal distances apart. Is it occasionally irregular? If it is, that could mean you have a premature ventricular contraction. Or is it regularly irregular, or is it very, very irregular? And that'll kind of help determine if you have just some premature beats or if your underlying rhythm is irregular. And as you practice EKGs more frequently, you'll be able to see, hey, this one R wave is early and I have this wide and bizarre QRS, I must have a premature ventricular contraction or a PVC. Or, whoa, this rhythm is very, very irregular. Something else is going on. Next, you want to assess those P waves. Are there P waves present? Are they upright? Are they uniform? Do they occur at a regular rate? Is there a P wave before every single QRS? Next, you're going to measure your PR interval. And generally, your PR interval is going to be between like 0.12 seconds and 0.20 seconds, or 3 to 5 small boxes. If your PR interval is greater than 0.20, you are in a first degree heart block. And what your PR interval is measuring is the time it takes for that electrical impulse to travel from the atria to the ventricles. So you're looking for a heart block. Next, we are going to measure that QRS duration. And generally, it's going to be less than 0.12 seconds, or about 1 to 3 small boxes. And we're looking at the QRS duration to see if there's any problems within the ventricles. And a lot of times, you don't even need to measure it to see if you have a ventricular problem, because you'll see this wide and bizarre QRS. It's going to stick out like a sore thumb. Now that we've gone through each of the steps, let's practice. First, let's look at that rate. Remember, we had 9 complete QRSs, but you see at the end, you see part of one. So we could say the beat is 90 to 95 beats per minute if you want to count the half one. Now we need to march it out. We need to march out those QRS complexes. Yes, they are all equal distance apart. Next, we need to look at the P waves. Is there a P wave before every QRS? Are they all upright? Are they uniform? Are they equal distances apart? Yes. Now we need to measure that PR interval. Is it greater than 0.20? Do we have a first degree heart block? Absolutely not. It's 0.12. Next, we need to look at that QRS duration. Is it greater than 0.12? Does it look wide and bizarre? No. So I know everything is in normal parameters. So I am normal sinus rhythm.